Thank you. Thank you. Before I start my talk, I would like to extend my warm regards to Dr.D'Pankar Banerji, sir. He has given me first opportunity to talk about bone marrow transplant or stem cell transplant in pediatric patient. So I have got a very good response after that, and I have also taken one more session on sickle cell in pregnancy. So I'm a pediatrician, so my perspective will be little different. So if you have any doubt, you can ask me any question. If you have, you can talk to me later. So before I start my talk, I know there are many questions in your mind because you guys are gynecologists. So whenever you have a pregnant lady, they would come to you and say, I would like to preserve my cord blood. So I'm sure most of you would have answer, but I would like to help you out in saying the answer whether it is strongly yes or no. I hope at the end of the session we would have this answer. So before going ahead, my talk is on cord blood stem cell transplant. So I will be touching upon what are the utility of cord blood in procedures other than bone marrow transplant, because all of you would like to know more about that rather than umbilical cord stem cell transplant. So since the talk is on transplant, so just a few words, just few slides on transplant. So what is bone marrow transplant or stem cell transplant? So bone marrow transplant is a misnomer basically. So it is just the hematopoietic stem cell transplant. So what are the hematopoietic stem cell? All of you are gynecologists, so you know better than me. The pluripotent cell and the totipotent cell. The totipotent cell means it has potential to develop into any cell of your body, like fertilized egg. Then the second is pluripotent cell. Pluripotent cells are mesenchymal stem cell, then hematopoietic stem cells. So they are there in your body. So they are there in your bone marrow. So they can be differentiated into your blood cells like RBC, WBCs and platelets. So in this picture, as you can see, a patient who is diseased. Diseased means it can be leukemia, lymphoma, or any of the bone marrow disease. Or you can say disease of RBC like thalassemia, sickle cell anemia, disease of WBCs like immunodeficiency disorder, disease of platelet like Glanzmann thrombocythemia, and so on and so forth. So any of the disease of blood cells. So because of that, the marrow is damaged. So or it is because of some genetic problem, the RBCs are dysfunctional. So what do we do is we are going to replace this marrow from a healthy marrow, or you can say a donor marrow. So here you have a diseased marrow, and then on the right side you have a healthy marrow. So the picture looks very simple, but the process is very complex because you have to destroy the patient's marrow completely by giving chemotherapy. So what are the sources of stem cells? So when we talk about umbilical cord, it is a very readily available source. I'm sure you must know, every day you deliver a baby and many people just throw it out. So it is such an important thing, and that can save lives. So other two commonly used sources are bone marrow and peripheral blood. So umbilical cord is also a very key source of stem cells, so that can save lives. This is how the transplant is done. So first we identify the patient who has a problem. Problem means problem of RBC, WBC or platelet, which I have already told you, or any genetic disorder or any of the disease. So we give, because you have to have a space, like if you have a flask filled with water, you cannot fill anymore. So first you have to empty the box or empty the flask. So the emptying of flask is being done by conditioning or chemotherapy. So we just give chemotherapy to empty that flask, and we fill the cell. We fill what cell? We fill the donor cell. So basically we extract the donor cell and give it to the patient who has a disease. So this is all about transplant. So we have three sources. One is bone marrow, second is peripheral blood, and umbilical cord. So I will tell you one by one how do we collect stem cell. So this is first procedure, that is bone marrow harvest. So this is was done in 1946. So here we lie down the patient on supine position, and we take 5 ml aliquots of blood, and we collect the blood into a bag. So see, you can see a patient lying down on the table, and a doctor or a bone marrow transplant expert, he is extracting the bone marrow from the posterior superior iliac spine. So like, I think if you would have seen the bone marrow procedure, it is just like same. Only difference is we don't collect stem cell for, we don't collect the marrow for diagnosis. We collect the marrow for therapeutic purpose. So we cannot collect 5 ml, 10 ml. We have to collect 15 or 20 ml per kg of the bone marrow. So for example, if baby's weight is 10 kg, so how much are you going to collect? 150 to 200 ml. So we collect in 5 ml aliquots. We keep it in a bag which is already filled with a anticoagulant, that is heparin and ACD. So one sister will be sitting next to you or standing next to you. We'll keep collecting 5 ml. If we give it to the sister, and she will be collecting those 5 ml of bone marrow in a bag. So this is how we do the bone marrow harvest. So this is very invasive procedure. As far as donor is concerned, we have to put him under general anesthesia. He might require a lot of drugs, medications, so their life is at risk. So what are the other options? The second option is peripheral blood stem cell. It is very easy. You can see a patient lying down on the bed, and nicely from the cubital vein the stem cells are being collected. So this is a kind of OPD procedure. So like you must have seen the collection of single donor platelet via apheresis. So it is just like that. So there is a apheresis machine on the right side. Patient is lying down and we collect the stem cell. But you might be having a question that it is just peripheral blood which is being collected. No, it is not like that. We give a GCSF injection which mobilize the bone marrow cells from the bone marrow to the peripheral circulation, so that we can collect the selected CD34 selected stem cell into the bag. So the bag which is red in color, that has CD34 selected bone marrow cell, and the remaining, the plasma, the other things will be given over to the patient. So this is how we collect the peripheral blood stem cell. So this is nowadays routinely practiced procedure because there is no risk to the donor. Then we calculate the stem cell. So this is not important for you. We just collect that how much volume of CD34 cell we have calculated. So ideally 2 to 4 million per kg of cell we used to collect per kg. So when we compare the different kind of stem cell collection procedure, the bone marrow is the invasive one, the PBS is minimally invasive, and the umbilical cord is non-invasive. Now we come to the point about umbilical cord blood transplant. So umbilical cord is like a waste thing. Now you just discard it each and every day. So ideally what we do is we just clamp the cord, and we immediately with the 16 gauge needle we used to collect the blood into a bag. So there are cord blood bank which already send you a bag. So that, and they only will come and collect the stem cell. So first time the study of umbilical cord began in 1960. So about 1 in 3 hematopoietic stem cell transplant are done with cord blood. So I will tell you, it is such an easy and ready to like available source, but still we don't use it. Why? I'll let you know later. So the blood which is left out in the placenta and umbilical cord can be taken and stored to be used for stem cell transplant later in life. So this is the YouTube, I think you can go through the procedure if you want. So I'll just brief you how it is being done. So pre-transplant patient receives other form of treatment that I have already told you. Then the cord blood is being obtained. The transplant will be decided and done by the physician, and the post-transplant we need to see the recovery of WBC, RBCs and platelet. So this is very extensive. I'll just brief you what it is. So basically first 1988 pediatric transplant was done through a umbilical cord in a patient who has Fanconi's anemia. So Fanconi anemia is nothing, it's a type of aplastic anemia where genetically the bone marrow is defective. So it is not going to get corrected unless you do something. So you have to replace the diseased marrow by a healthy marrow. So ideal source is stem cell, and the stem cell, the easiest way to collect the stem cell, as I have already told you, cord blood. Cord blood is the easiest way. So they have done, many scientists have found out that this is a very easy way to collect the stem cell and give it to the patient. So what are the uses? So 1980, earlier they thought that there could be 1 or 2 diseases which can be treated, but later when the time goes on and the advancement in the process is being done, so now many diseases, like more than 80, now at present more than 180 diseases can be cured, can be treated by stem cell transplant. So first of all, many people say that preserve the cord cell so that you can use it for future use. If you have a disease, then it will be used. So it's all misnomer. Why? Because it is not a cure. It is going to regenerate. It is a kind of regenerate. It does not assure you that it is going to correct the disease altogether. It is just going to help in recovery. So it is used to regenerate healthy blood and immune system after it is being damaged by the disease like thalassemia or sickle cell. Mostly used in children and small adults. One more important thing is how much volume we can collect. All of you must have seen how much umbilical cord blood is being left out. Hardly it is it ranges from 20 to 140 ml. So if you calculate the stem cell amount, the CD34 count, it is hardly going to be 0.5 to 1. Whereas for a transplant, we require little higher dose, 2 to 4 million per kg. So that way, that is why it is not a procedure or stem cell procedure of choice, because we are not going to get adequate amount of stem cell, because the volume is very, very less. The volume is very, because when you see, I'll just go through this slide because this is very important. So when we calculate the stem cell, see you have CD34 per kg in the last line if you see. So 2407 CD34 cell multiplied by volume. So this 425 is volume. So ideally through bone marrow harvest or peripheral blood stem cell, we used to collect blood ranging from 200 to 400. So even if the baby's weight is 10 kg, minimum volume required is 200 ml. Whereas with good amount of umbilical cord blood also, the maximum volume which you can collect is hardly 100 to 120 ml. So thereby it is not the ideal method or ideal source which can give you adequate amount of stem cell. And whatever literature or studies have said, the transplant success is directly proportional to this CD34 stem cell count. So when we would not be able to extract the adequate amount of stem cell, how it is going to be useful? So that question comes in everybody's mind. So though it's a very good, a beautiful source, an easily available source, but the problem is the stem cell count. So that is why people are doing multiple things. They are doing double blood umbilical cord. 2 times they are taking the umbilical cord blood and giving it. But there are problems. How do you get that blood? Then the restriction in the number of public or private blood banks. So how do you get it? How do you get the HLA matching done? So these are the problems with the cord blood transplant. So but there are other cells. The umbilical cord does not only contain stem cell. It has many other cells like the other regenerative cells. I'll tell you later. So these are the disorder in which you can use the umbilical cord stem cell. There are multiple immune disorder, the cancer cells like ALL, AML, most commonly used in relapsed and refractory settings. Then blood disorder, mostly you should know about aplastic anemia, thalassemia, sickle cell anemia, pure red cell aplasia. Then the metabolic disorders, Gaucher's disease, Krabbe's disease, Leishman's disease. So these are the diseases in which it can be used. So this is about the cord blood transplant, why it is a good source and why it cannot be used for ideal source for transplant. So I will further clarify your queries, but what are the other uses of these stem cells? Then autism, you must have come across this disease of the central nervous system. So there is a problem with neurotransmitter regulation. So it actually helps in recovery of these defective neural cells. So how does it help? Because it has inducer potential. So it induces the left out damaged cells. So it induces what are the left outs, whatever healthy cells are, suppose 80% of the cells are damaged, but still 20% cells still has potential to grow. So it helps in those left out cells to grow and to help in further regeneration. Thereby it is of use in autism. Then cerebral palsy. Again, cerebral palsy is a disease of the infants or pediatric age group where there is complete hypoxia or many problems in the neonatal life which can lead to cerebral palsy. So it helps in regenerating those damaged cells. So basically the concept is same. Only thing is in which disease it is proven. So the trials are going on in whatever disease I am telling you, the trials are going on. So it is not a approved drug, it is just under trial. So if you want to use, you can use it only as a part of clinical trial. You can't simply get the stem cell and use it. So cord blood stem cells are also capable of giving rise to hematopoietic, epithelial, endothelial, and neural tissue. So it is not just the hematopoietic cell which is left in the cord. So you have epithelial cells, you have endothelial cell, you have neural tissue. So whatever diseases are there which are terminal terminal diseases, motor neuron diseases, cerebral palsy. So in these terminal diseases where there is no hope, there is no option. So in those diseases, at least we can try out this option, which is available and readily, it can be available in India also. So if you want, you can do of this trial and prove it. So again, it is a very useful thing because it has mesenchymal stem cells also. Again, in stroke, this use is same, or osteoarthritis, again it is same. Rheumatoid arthritis, autoimmune disorder, because earlier what I told is terminal degenerative diseases, which cannot be cured by normal medical treatment. Rheumatoid arthritis is an autoimmune disorder. Autoimmune disorder, as you know, there is an imbalance between your regulatory cell and cytotoxic T cell. So very important key thing in cord blood cells it has more number of regulatory cells. So the T regulatory cells, it is going to control your immune system. So thereby it helps in all your autoimmune disorder, whether it is SLE or rheumatoid arthritis, and all of you must be knowing, you come across many cases of SLE and rheumatoid, there is no cure. They keep on coming and getting the medications. So why not to put them under trial, who are refractory and relapse cases and they are keep on suffering. So we can put them on these cells and you can easily get through a cord blood bank, and then you can do a trial and see. It has a very good effect rather than stroke or cerebral palsy. It has more proven role in autoimmune disorder. Then again, spinal cord injury. Your cord is damaged. So there are trial which says that it is again useful. It helps in regeneration of those damaged cord cell. And there, some people have tried giving directly into the intrathecal space, 4 to 5 ml of cord blood into the space, and they found that the patients have improved. And that has been used along with IV infusion of cord blood cells. So the benefit I have already told you, it is proven to treat hematopoietic disorder. It is a proven treatment. The cord blood transplant is not under trial. It is a proven treatment. But whatever I have told earlier, whether it is in rheumatoid arthritis or autoimmune disorder or heart failure or spinal cord injury or autism or cerebral palsy, this use is under clinical trial only. One umbilical cord generally contains enough number of cells only to treat a small baby and a very small adult, and in adult also, small adult also, you need to have 2 umbilical cord blood. Previously treating with 2 different donors has been effective, which is reassuring in showing how adoptive cord blood cells are. There are certain disadvantages. It is very, very expensive. Chances that a patient is exposed to rare genetic disorder, so which is not manifested earlier. It may take a decade or 2 before this is definitely a cure to a deadly disease, which I have already told you. So it is not yet a curative treatment, it is just under trial. The average size or larger adult were not thought to be able to benefit because the amount of cell that they want is more than what is available. So what are the ethical problems? Sufficient donation from different ethnic groups is still required. Public storage whenever possible. So I will tell you one more thing. There are 2 types of cord blood bank. One is public, second is private. Private, you all know, you have to pay for it and it can be used only for the patient who has saved it. Public blood bank like G1 in India, it can be used for a non-self purpose, like if somebody wants to do a trial or if somebody wants to treat the patient by umbilical cord transplant, so they can go for public blood bank. In outside world, there are millions of cord blood cell which is stored, but in India, number is hardly 5 to 6 lakhs. So that is a limitation. So we don't find exact match also. That is another limitation because people are not aware of. Everybody has many myths regarding cord blood and nobody is aware of. Even the doctors have limited knowledge about this cord blood utility. So you have to take informed consent. Right to self-determination, the laws are there already in place in USA as well as in India. ICMR also let down some line to use this umbilical cord blood. So the new model of business that the sells only the hope on future use. So we at present, again I'm stressing on this point that it is not a curative option at present, it is still under trial. It has only been proven to be used as a cord blood for stem cell transplant. So cord blood stem cell transplant is the only proven use for umbilical cord blood. Others are again the myths. Again, the misinformed mother, that is the problem in India. So first thing is they claim your mother will, the private blood bank, whenever you go to their site, they will ask your child will most likely need their stored blood, so please store it. The company claim that 1 in every 50 children, they need it, which is wrong. Then second claim they put is the child can use their own cord blood to treat leukemia. But I must tell you, the leukemia is again a problem of genetic mutation, which might be there since birth itself. Only thing is it has not been manifested. So you have to be very careful about this. Again, stem cell use in cord blood can be used as a cure for all adult in treating many diseases. That is again wrong. It is not proven. It is under trial. Finding a stem cell donor is often impossible. It is not impossible. If you go to foreign registry, you can get it immediately also. And the Society for Obs and Gynae America and the American Academy of Pediatrics, they does not recommend cord blood banking there. So proposed changes, they have proposed some changes that allow donor to have the right to know what exactly their donation will be used for and how they are being used, and allow donors to obtain profits from the products or tests developed from their sample. Then duty to feedback. If you are using for a trial, for a research purpose, they need to know about for what purpose their preserved blood has been used. Now, last few slides, there are some myths. Suppose a child, for example, this child is suffered from osteopetrosis. Osteopetrosis is a disease of the bone marrow, in which the bone marrows are, or you can call it as marble bone disease. It is a very rare genetic disorder in which the space is so narrow that later on it just stops producing stem cells. So the only treatment is transplant. But can you save this child from these stem cells? Suppose these parents have preserved blood for this child. So can we use this blood for the transplant of the same child? The answer is no, right? Because stem cell, he already had a disease which was not told to him. So if the person is suffering from genetic disease, how could he use his stored blood for his treatment? It is not possible. So before you preserve, you must tell that if he is suffering from any sort of genetic disease later, we don't screen out each and every disease at present. So that is why if they suffer any kind of deadly disease or genetic disease, it is of no use. Thalassemia, it is of no use. Sickle cell anemia, it is of no use. Any genetic disorder, metabolic disorder, it is of no use. So you have to tell the patient. So then what is the use? Then second, if a patient is having AML, so again AML, they say it can be used, but again the problem is they might carry some sort of mutation. So again you are going to, he is going to suffer later on. So the question is again unanswered. So after hearing this presentation, would you bank your child's cord blood? So this question you should ask to each and every person. So I think I will make this presentation available to you all so that you can again go through it. So my question is, if somebody asks you the question, you have to answer clearly that the use of cord blood is only for the transplant, and basically it is like a donation that can be used for somebody else who has thalassemia, somebody else who has sickle cell anemia, who is actually matched with your kids, so that they can have readily available stem cell source. But other uses, like uses in degenerative disorder, uses in heart failure, uses in other sort of degenerative disorder, the use is still under trial. So you have no answer of these questions. So if you answer yes, then would you choose a public or private bank? Again, because I have already told you, the recommended treatment is only for cord blood transplant. So basically we should opt for public blood bank. Private, they will just make money out of it and they will not tell you the exact answer. So emerging technologies and future direction. So there are advancement in stem cell mobilization so that the number of the stem cell count can be increased. Then gene therapy and stem cell is coming up. So this combining gene therapy with stem cell transplant, especially in sickle cell anemia, is again a future hope for us. And then induced pluripotent stem cells, so which whatever we have already seen earlier, the use in various disorder, it is by induced pluripotent stem cell. So that can be utilized for any of the degenerative
Smita,
disorder.
Please be fast.
It's ma'am, that was the last slide. So that was the conclusion of my presentation. So basically, cord blood stem cell is a very good option for stem cell transplant, but again, the uses are limited. It is used for small baby like 5 kg, 6 kg, 7 kg baby. It is a very curative and effective treatment. For other diseases, it is still under trial. So the answer still, we are yet to get the answers. Any questions? Thank you.
Thank you, Dr. Smita Pathak, for your informative and interesting talk on stem cell transplant and cord blood collection. And I think 50% wants to preserve it and 50% knows that it's of no use at present.
Yes, ma'am.
So, and
yes,
you have cleared our doubts also.
Yeah.
So thank you very much.
Thank you.
Sorry for interruption, ma'am. I request D'Pankar sir to please come on the stage and felicitate Shweta madam. In the meantime, I request Dr. Deepti Gupta to please come on the stage. I will request Pradnya madam to please come on the stage. I'll request D'Pankar sir to please come on the stage so that we can felicitate the winners of the quiz. Dr. Ayushi and Dr. Deepika. Dr. Ayushi, Dr. Deepika. I'll request Vivek sir also to please join us so that we can felicitate the students.
Congratulations. Thank you.
Congratulations.
So big round of applause for Ayushi and Deepika. They are actually second year residents, not even final year.
We'll request the second prize holders, Dr. Mahi and Dr. Shraddha, to please stand in queue.
And apart from certificate, first prize is rupees 5,000. What is the Ideal Fertility Center? Second prize is 3,000 and third prize is 2,000.
The second prize winners, Dr. Mahi and Dr. Shraddha.
Shraddha,
The third prize winners, Dr. Rishu and Dr. Vallabhi, to please join the queue.
and third place, Rishu and Vallabhi.
We have certificate of appreciation for Dr. Megha, Dr. Isha, Dr. Vipasha, and Dr. Shivangi.
Shivangi and Vipasa are still finishing lunch. Megha, Isha. Shivangi, Vipasa.
Shivangi and Vipasha, if you are listening, please come on stage.
Thank you, ma'am. And as you rightly mentioned, FGR is one topic which is always more of questions than answers. So what I've tried to do is to take this lecture as 10 frequently asked questions about FGR, and then at the end of it, let's see how far we can go in terms of answering these questions. So the first question people ask me is, your definitions for fetal growth restriction keep changing every month, every year. What is your current definition? This is a very valid question because it is true that guidelines and the criteria for diagnosing FGR keeps changing from time to time. So this does cause a lot of confusion. Now, we're all familiar with the concept of birth weight. Okay, birth weight is a very discrete variable. You can say 2.8 kilos, 2.94 kilos, 2.738 kilos, etc., etc. Now, unlike this, growth is a continuum. Okay, you cannot really pinpoint a point in growth and say this is this measurable variable. So you cannot really measure growth because growth, as we say in statistical terms, is an indiscrete variable, something that you cannot really measure. And this is beautifully brought out in the definition of fetal growth restriction, which you heard Dr. Deepti mention has never changed. Make no mistake about the fact that criteria for diagnosis have changed, but the definition of growth restriction has always been one and the same, which is the failure of a fetus to achieve its endorsed growth potential. So this drives home the fact that every fetus has its own growth potential, and if for whatever reason that fetus does not live up to its own growth potential is when you would diagnose fetal growth restriction. So that is the definition. The definition has always stood the test of time. Now, for better understanding of this definition, you can compare this with what we call as failure to thrive in a pediatric age group child. failure to thrive in a baby who's 2 years old can probably be because of nutritional deficiency if he or she is not taking enough nutrients. It could also be because of disease like acute diarrheal diseases, tuberculosis, typhoid or influenza, whatever disease that can happen in the child. Now, much in the same line, your failure to achieve growth potential, as we call it in the fetus, could also be because of deficiency, nutrition deficiency, or it could be because of disease. In our terminology, deficiency is related to as insufficiency or uteroplacental insufficiency, and which is what we call as extrinsic growth restriction, or if it's a disease, you call it as intrinsic growth restriction. So it's exactly similar to the failure to thrive concept as extrapolated to fetal life. Now, having said that, how can you really measure the growth potential of a fetus? We said it's a failure to achieve the growth potential. How do you measure fetal growth potential? Now, it would have been wonderful if we had something called as a growth potentiometer, but AI, for all it has achieved, has never got to that point where you can actually measure the growth potential of a baby inside the mother's womb. And therefore, you need a proxy. And that proxy that we use is the fetal size. So we are assuming if you look at fetal size, you can predict fetal growth. So that is the proxy that we use. And because you use size as a proxy for growth, smallness by default automatically becomes a proxy for growth restriction. Okay. So then we said about smallness. How do you define smallness? Now, smallness of fetus is considered small if the measurements that you make for that fetus fall below an arbitrary cutoff that you lay out. And that cutoff that you lay out is what we call as the 10th centile. So if you have a fetus whose weight or AC, abdominal circumference, is below the 10th centile, you say that that fetus is small. So you plot the growth of that baby. You plot the estimated fetal weight on what we call as a growth chart, like you have in the neonatal and the pediatric population. And you plot the growth of this particular baby on the growth chart, and the growth falls below the 10th centile curve is when you say that this fetus is growth restricted. So then that automatically brings us to the next question: which growth chart is the best? This is again a very often asked question, but this is always a controversial question. It's a never-ending debate. There are several types of growth charts: reference charts, standard charts, customized charts proposed by different organizations. But if you ask me, at the end of the day, you cannot pinpoint and choose and say that this chart is better than the other. Each of these charts have their own advantages and disadvantages. You have studies from India, you have studies from abroad. All of them pretty much conclude the same thing. So my take on this is, make sure that you use the chart, validate this chart in your local setting and workflow, but never use the chart as a standalone entity. You'll always use it in conjunction with Dopplers. And therefore, if you're using it along with Dopplers, which chart you use does not carry too much of a significance. It's only important that you definitely use the chart to predict any sort of growth abnormality. Now, we said we use smallness as a proxy for growth restriction. There are two major assumptions we make when we do that. So if you say smallness is growth restriction, you're trying to say that all small fetuses are growth restricted. You're also trying to say that all growth restricted fetuses will be small, and we know that both of these statements are not absolutely right. Because we have data, we have enough data that says that not all small babies are indeed growth restricted babies. In fact, you have a family where the father is small, the mother is small, the grandparents are small, the uncles and aunties are small, the first sibling is small. You would obviously expect this baby to be small as well. In other words, there's nothing that restricts the growth of that baby in utero. Rather, it's just a familial smallness, and this is what we call as constitutional small babies. So that is not a growth restricted baby, because there's nothing in utero that is hindering the growth of that particular baby or preventing that baby from reaching its endorsed growth potential. So here is a case where the endorsed growth potential itself is small, and therefore the baby is small in growth. Now this forms a very small chunk of all your small babies. A small 10%, let's say, would be constitutionally small, but whereas the vast majority will indeed be growth restricted. Now the second assumption that we said is all growth restricted fetuses will be small, which again is not always correct, because if we look at this particular growth chart, this baby started off close to the 90th centile here. It came to the 70th centile at 28 weeks, and when it came to 34 weeks, it has touched the 10th centile. So there's almost a 70 or 80 centile drop in its growth. So does this mean that the baby is living up to its growth potential? Certainly not. If it was living up to its growth potential, the baby whose growth started here should have ended up here. So there's distinctly a fall in growth that's happening, and nothing better than a growth chart. One glance at your growth chart will tell you that this baby is not growing to its endos potential. There is something that is hindering the growth of this baby, and that, of course, would be a growth restricted baby, even though by definition it is still above the 10th centile. Now if you extrapolate this graph, it will certainly become small at some point in time, but at 34 weeks or even at 34 weeks, this baby is still not small in terms of your definition of the 10th centile, but this graph is very clearly telling me that this baby is not living up to its potential. So therefore, you're more likely looking at a case of growth restriction than a constitutional smallness here. Now, this is a very small cohort, I agree, but picking up this cohort is very, very important, because the vast majority of your term stillbirths happen to babies that are not below the 10th centile but above the 10th centile, but had not lived up to its endos growth potential. That's why, even though it's a very small subset, it is important to identify those babies that are still not below the 10th centile but have not been maintaining interval growth. So then how do you exactly diagnose? I've confused you enough. Now tell me, how will I diagnose FGR? We're not talking about intrinsic growth restriction, because that is something completely different. You can do a full half-an-hour lecture on that. And here again, we're not really worried about intrinsic growth restriction as far as decision making is concerned, because you find an anomaly, you find a chromosomal abnormality, your decision is pretty straightforward. So what we have problems, as Madam said, in taking decisions is with the extrinsic growth restriction. So the definition of extrinsic growth restriction is, in the absence of an intrinsic cause, you would consider a fetus as growth restricted if it satisfies 3 criteria. 1, it's extremely, extremely small. Second, it's small or not maintaining growth with a demonstrable pathology or a demonstrable extrinsic cause, which is uteroplacental insufficiency. Or, as I showed in the last example, it's still not small by your definition of 10th centile, but it's certainly getting there if you look at the growth chart, with demonstrable hypoxic changes in the fetus. So it tells you the fetus is undergoing some kind of stress, but it's still maintaining above the 10th centile, but eventually, sooner rather than later, it would come below the 10th centile. So if these are your 3 criteria, and to translate that to numbers, let's look what it holds. So when do you say a fetus is extremely small? A fetus is extremely small if its weight is below the 3rd centile. Now, how does this 3rd centile come into importance? If you look at this growth chart, this is a chart of birth weight centiles versus perinatal mortality. What this is trying to tell you is, I want you to focus on the red line. As the birth weight falls below the 10th centile, okay, somewhere there is a 10th centile, there is a significant increase in perinatal morbidity and mortality. Can you see that from here? Below the 10th centile, there is a rapid rise. But when it falls below the 3rd centile, that's your 3rd centile point, look how exponentially there is a rise in perinatal mortality. So that's why the 3rd centile cutoff came into existence. Any fetus that is below the 3rd centile in itself is growth restricted, irrespective of the other criteria that you would want to use. Now, that's about extremely small. The second criteria we said is a baby that's small or not maintaining growth and has a demonstrable extrinsic cause of uteroplacental insufficiency. This is what we call as SGA FGR, or small for gestational age fetus, which is not constitutionally small but growth restricted because you have a demonstrable cause there. Now, this is very easy to pick up if you do a growth chart on a centiles curve. Versus the fetus on the left, which is small but maintaining its growth, the fetus on the right is small and not maintaining growth. So which is more likely to be growth restricted? Obviously the one on the right, because it's not maintaining its growth either. And the second part of that definition is you need a demonstrable extrinsic cause. Now, when you say demonstrable extrinsic cause, you could either demonstrate that the placenta is bad by looking at Dopplers, or you could show that the fetus is trying to compensate or adapt to the insufficiency by looking at fetal Dopplers. So if you have uteroplacental insufficiency on the one side, or if you have fetoplacental insufficiency on the other side, that becomes your demonstrable extrinsic cause as far as the definition is concerned. And I'm sure all of you are very familiar with the pathophysiology of this. You have to start off with a bad placenta. The trophoblastic invasion does not happen properly, and therefore the uterine artery spiral arterioles are not rendered inelastic as they should be, and therefore there's high resistance to flow in the uterine artery. So the uterine artery blood flow to the placenta is reduced, and when the blood flow to any organ is reduced, what happens is that organ undergoes ischemia. If the coronaries don't supply blood to the heart, you get coronary ischemia, you get myocardial infarction. pretty much if the uterine arteries don't feed the placenta, you get a placental infarction. So once there is a placental infarction that happens, ischemia eventually leads on to infarction, and once infarction happens, the available surface area of the placenta becomes limited, because an infarcted placenta cannot do its job, or infarcted areas within the placenta cannot do its job. So what happens is that the available placenta, which is really available for surface or for gas exchange, becomes very, very limited. And therefore what happens is the oxygen saturation in the umbilical venous blood that goes back to the placenta becomes less, because the oxygenation is not happening properly. And when there are multiple large areas of ischemia that occupy more than around 30% of the placenta, the placental vascular resistance becomes very high, and that becomes manifest in the artery that flows into the fetal side of the placenta, which is the umbilical artery. So when more than 30% of the placenta is ischemic, the placental vascular resistance is very, very high, and that reflects as reduced diastolic flow in the artery that flows into it, which is the umbilical artery. Remember, in any blood vessel in the human body, you have systolic flow and diastolic flow. Systolic flow is dictated by the pump, whether by the cardiac pump, whereas diastolic flow is dictated by the resistance offered by the end organ. So if you look at the umbilical artery, the end organ here to which it flows into is a placenta. So if your placental resistance is very, very high because of ischemia, it reflects as reduced or absent or reversed diastolic flow, depending on the severity, in the vessel that flows into the placenta, which is the umbilical artery. And when the oxygenation does not happen adequately, what happens is that the saturation of oxygen in the umbilical venous blood that flows back to the placenta is reduced, and that is what we call as the onset of fetal hypoxia. Now, so if I say you have to have a demonstrable uteroplacental insufficiency, you would look at these entities here. You look at the uterine artery because it flows into the maternal side of the placenta. You look at the umbilical artery because it flows into the fetal side of the placenta. Now, the fetus is a very smart being. The moment it senses that it's not getting enough oxygen, it has its own mechanisms by which it can auto-regulate its blood flow and redirect more blood to try and save the most vital organs of the body, which is the brain and the heart. So this is what we call as brain sparing or cerebral redistribution, and this becomes manifest as changes in the MCA Dopplers and in the CPR. So therefore, to speak about that demonstrable cause, you can either show abnormalities in uterine artery blood flow, or you can show abnormalities in the umbilical artery blood flow, both of which would tell you the placenta is bad, or you can show signs of compensation in the fetus by looking at fetal Dopplers. Particularly early on, it would be the middle cerebral artery Dopplers, and of course the cerebroplacental ratio, because this becomes abnormal before both of these Dopplers individually become bad. So that was the second criteria. Now we come to the third criteria, which says if a fetus, as I showed in that particular case of AGA FGR, not small yet, but if you look at the growth centiles, it is definitely getting to be small, and you also have demonstrable changes in the fetus telling you that the fetus is trying to really compensate. This is what we call as AGA or FGR in the AGA group. Now the tools that you would use to diagnose this is exactly the same: growth charts and Dopplers. Growth charts I showed you, how if you see there is a crossing of centiles, it's dropping by more than 50 centiles here, so this baby is obviously not living up to its potential and therefore is likely to be growth restricted. And in Dopplers, when it comes to Dopplers in this particular subset of fetuses, here it will be fetal hypoxia and the fetal adaptive changes that will be much more evident than the placental changes, because maybe 30% of the placenta is still not abnormal. It's around 25%, so the umbilical artery might still not show an abnormality. So there may not be signs of uteroplacental insufficiency, but certainly when you look at fetal Dopplers are bad, so that tells you that the fetus is trying to adapt, and you have a fetoplacental insufficiency in the Dopplers there. So if you find a drop in growth velocity, a significant drop in growth velocity with an abnormal brain Doppler in the baby or an abnormal CPR in the baby, that tells you that this fetus is calling out for help. It is hypoxic, combined with the fact that you have the growth chart telling you that there is a fall in growth. That is again a classical diagnosis of fetal growth restriction in a so-called appropriately grown for gestational age fetus. Now the importance of CPR, as I said, is much more sensitive than the MCA. It becomes abnormal before both the umbilical and the MCA becomes abnormal. And if you look at the longitudinal change in each of these Dopplers with time, the most pronounced effect is in CPR. which is why we give a lot of weightage to CPR in the diagnosis of growth restriction in late onset FGRs and in the AGA FGR group, because the change in CPR is dramatic, much more dramatic compared to your change in MCAs or in the umbilical artery Dopplers, which is why CPR scores above all the other Dopplers, particularly in late onset FGR and in FGR in the AGA group. Now, the sixth question that's asked often is, what is early versus late onset FGR? Now, as I said earlier, growth is a continuum. Very similarly, fetal growth restriction is also a continuum. It's a disease in evolution. And as I said, depending on how much of your placenta is affected, you could have two distinct phenotypes of the same disease process of FGR, which is what we call as early onset and late onset FGR. Now, as I said earlier, it's only when more than 30% of the placenta becomes infarcted that the umbilical artery really starts to show an abnormality. So what happens in very bad placental disease is, let's say 50% or 60% of your placenta is affected, and therefore your umbilical artery Doppler is always bad in these cases, and these babies start to become growth restricted very, very early, and that is what we call as early onset growth restriction. You have a very bad placenta, the fetus cannot live up to its growth potential, it becomes small very, very early in gestation, and because the placenta is more than 50% damage or 60% damage, the umbilical artery also shows an abnormality. So that is one phenotype. And on the other hand, you have a baby's placenta that is maybe 25% ischemic, so therefore the umbilical artery Doppler is normal, but 25% ischemia is still significant in terms of less oxygen being delivered to the fetus. So the fetus starts showing signs of compensation or autoregulation, but the umbilical artery still shows a normal Doppler. So this can be misleading because you think the baby is normal, there's no growth restriction, but if you look at fetal Dopplers, it shows abnormalities telling you that the fetus is indeed less on oxygen. So this is what we call as late onset FGR. The onset of FGR itself is late because the placenta is not too bad like in early onset, but your diagnosis becomes difficult because the umbilical artery shows normal values. And this, in fact, forms the larger chunk because the early onset FGR is a very small subset. I'm sure all of you would agree that you see FGRs much more commonly later in gestation than the very severe phenotype which presents very, very early. In fact, the late onset FGR makes up around 80% of all the FGRs that you would see in your clinic. Now, if you have to arbitrarily say a cutoff in terms of gestational age, that cutoff would be 32 weeks, because usually early onset growth restriction would present before 32 weeks because the placenta is really bad, whereas late onset usually presents after 32 weeks. But having said that, this is not a watertight compartment. There could be a significant overlap between the two, as you can see from this graph as well. There is a significant overlap that happens between the two. But 32 weeks is roughly a cutoff that you can use in case you need an arbitrary cutoff to document. So like we said, in early onset FGR, the placental disease is really bad, which is why you have bad Dopplers, whereas in late onset, the placental disease is not so bad, therefore your umbilical artery Doppler could still be normal. And the problem we said with early onset FGR is management, because at 24 weeks, 22 weeks, you cannot deliver and save these babies. Whereas in late onset FGR, if you diagnose FGR at 36 weeks, you can very well go ahead and deliver if it is indicated. But your problem there is diagnosis, because if you look only at the umbilical artery Doppler, the umbilical artery Doppler could still be normal, and therefore you would miss out on the diagnosis of late onset FGR. So whatever I've spoken up until now was put together in terms of a consensus definition that was published in the White Journal a few years back. And this reflects exactly the same things that we spoke about here. So I do not want to go into the details all over again. Again, here you see the AC, or the estimated weight below the third centile. What we call as extremely small is a standalone criteria for both. They've used again as a cutoff of 32 weeks for early and late, and then the other criteria was what we discussed very elaborately, so I'll skip that for want of time. So to put everything together, if you have a fetus that is small for gestational age, 10 to 20% of them could be the constitutional small group, where we said the Dopplers are normal, there's nothing restricting the growth, but the baby is small because their parents and grandparents are small. The other 80% would be true growth restriction, and in that, a small fraction could be because of intrinsic causes like a chromosomal abnormality, multiple anomalies in the fetus, infections, and so on and so forth. But there, the major chunk is going to be extrinsic growth restriction because of placental abnormality. And in the extrinsic group, you can have a small group that presents very early because of very severe placental disease, but a larger group that presents later in gestation because of a milder form of placental disease, and which is easily likely to be missed. And if you look at AGA babies, The vast majority of them are going to be normally growing, but you could have a small subset which is growth restricted, which might be difficult to pick up because they weigh above the 10th centile, and almost all cases of AGA FGRs would be presenting late in gestation. The seventh question is, how do you really manage FGR? So that's where things start getting a little tricky. Now, we must understand that the only definitive treatment for growth restriction is delivery. Calcium doesn't work, bed rest doesn't work, protein supplementation doesn't work. None of the interventions have been shown to be definitively useful in treating FGR. The amnio infusions don't work, the L-arginins don't work, no protein supplementation works. The only definitive treatment is delivery. So it becomes very important as to how you time delivery. And your goal as a clinician is to deliver a baby that's reasonably oxygenated, as in not too hypoxic or not too acidotic, at the same time not too premature as well, because we need to be wary about lung maturity as well. And in this context, we also need to understand the subtle difference between hypoxia and acidosis. Now, there's something called as a hypoxic ladder. Now, it starts off with mild hypoxia. As we said, when the oxygen saturation in the umbilical vein is less, the baby senses hypoxia. That is mild hypoxia. And if you don't intervene at that point, if you don't deliver at that point, it progresses to severe tissue-level hypoxia. This tissue-level hypoxia in its next stage would accumulate bicarbonate in the fetus, and then it becomes respiratory acidosis, and eventually you have tissue anoxia happening that eventually leads on to anaerobic metabolism, formation of lactic acid, and that leads on to what we call as metabolic acidosis. So this is a sequential progression from mild hypoxia to severe hypoxia to respiratory acidosis and eventually to metabolic acidosis. And we also need to understand that babies don't respond to hypoxia in the same fashion when they are early onset growth restricted versus late onset growth restricted. In early onset growth restriction, we said there is a systemic cerebrovascular adaptation. So it's always the two most important organs in the body, which are the most oxygen dependent bodies, are the brain and the heart. In early onset FGR, the placental disease, we said, is very, very severe, and therefore there's a lot of resistance to heart outflow. The peripheral vascular resistance of the placenta is very, very high. Therefore, the heart fails very early, and it's the heart that takes the brunt of the disease in early onset FGR. Whereas if you talk of the brain in early onset FGR, the brain is quite immature at 24 weeks, 26 weeks. The brain stem is quite immature and is tolerant to hypoxia, unlike the heart is. So if you have a severe growth restriction at, say, 23 or 24 weeks, between the heart and the brain, we are more worried about the heart. But if it happens later in gestation, the placental disease is mild, so the heart does not have to pump against too much resistance in the placenta, so the heart gets relatively spared. The heart is also bigger by now, but what happens later in gestation is that your brain stem is completely mature. And remember, the brainstem is where your cardiorespiratory center is. All the corticospinal tracts traverse down the brainstem, and that brainstem in a mature brain is very, very, very sensitive to hypoxia. So in late onset FGR, the brunt of the disease is borne by the brainstem and not so much by the heart. This is a fundamental difference that we need to understand. And this also reflects faithfully in how you follow up these babies and how you survey these babies. In early onset FGR, because I said the primary target is your heart, is the baby's heart, we would look at the precordial veins, because that is what is flowing directly into the heart. And if you need to understand what's happening with the heart or predict what is happening, what's going to happen to the heart, you would need to look at the blood vessels that are flowing into the heart. In late onset FGR, we said it's the brainstem that bears the brunt, and therefore if you have to assess the brainstem, you have to look at the functions of the brainstem. And what does the brainstem do? As I said, the cardiorespiratory center is there at the brainstem, so you look at fetal breathing movements. All the corticospinal tracts flow through the brainstem, therefore you look at fetal movement, fetal tone, and the CTG. So all of this is what we combine together to call as a BPP. So as a surveillance tool, in early onset FGR, Doppler is much more important than BPP. But in late onset FGR, it is the BPP which supersedes Dopplers as your primary surveillance tool. I know it's a little confusing, but if you understand the concepts, all of this becomes very, very easy. So, as I said, the most important thing to do is to time the delivery optimally, because as I said, the most definitive treatment, perhaps the only definitive treatment for FGR, is to deliver these babies at the right time. Now, how do you understand when to deliver a particular case? It's always a throw-up between three factors: hypoxia, acidosis, lung maturity. So you would balance all of these three, and that is what will help you dictate your delivery. You forget what the guidelines say, because the guidelines say exactly the same things, but they put it in a tabular column. But if you understand why the guidelines say what they say, it becomes very, very easy. So this is basically a throw-up between these three players: hypoxia, acidosis, and lung maturity. Now, what are your signs of acidosis? Is the extreme signs in Dopplers. Your DV becomes bad. You have unprovoked late decelerations, which any obstetrician knows is a very, very severe insult to the fetus. So DV becoming absent or reversal is almost end stage. Unprovoked late decelerations, you and me know, is a very bad finding on CTG. If your BPP score is so bad to be less than 4, that is also very, very ominous for the child. So that is telling you that your fetus is acidotic. When you come to hypoxia, if it's severe hypoxia, is where you get the absent and diastolic flows in the umbilical artery. DV is not absent or reverse, but getting there, it's very high in terms of PI, and your biophysical score is somewhere between, say, 6 to 8. It's not less than 4, but it's between, let's say, 4 and 6. That tells you that the baby is severely hypoxic. Whereas if it's mild hypoxia, you just start to get abnormal flows in the umbilical artery and your CPRs. So this is how the Dopplers progress in terms of each of these. And where does umbilical artery reversed and diastolic flow fit in? Is between severe hypoxia and acidosis. So if you find reverse flow, you're sure that from severe hypoxia, the baby is progressing towards much more sinister acidosis. So as I said, ideally, you would not want the baby to become acidotic, because that has irreversible consequences to the brain and to the heart. Therefore, you would want to deliver before acidosis, but at the same time, you would want to avoid extremes of prematurity. So where do we draw the line? Which is the magic number? Now that magic number is 32 weeks. If you reach 32 weeks, you have enough data that tells you that your lungs or the baby's lungs is reasonably mature. So after 32 weeks, you're assured of lung maturity. Therefore, the moment you see severe hypoxia, you would deliver. You would not wait till acidosis. And what are your signs of severe hypoxia? Umbilical artery absent flow, DVPI above the 95th centile, or a BPP of 4 to 8 is severe, 4 to 6 is severe hypoxia. But if it's before, and certainly it goes without saying that if you would deliver if there's severe hypoxia, you definitely deliver if there are signs of acidosis anyways. But if it's before 32 weeks, your lung maturity is still in question. You're still not very sure of your lung maturity. So you'd probably give that baby a little more time and probably deliver only when it's starting to get to acidosis, which means when you start to see reversed and diastolic flow, you know it's progressing from severe hypoxia to acidosis, or you find definitive signs of acidosis like severe abnormalities in the DV, unprovoked late decelerations, or a BPP less than 4, you know this baby is really acidotic. So that is the time you would deliver any time before 32 weeks. Now, if you have reached term, then none of this matters. You would deliver even to the slightest hint of mild hypoxia, which is umbilical artery Doppler abnormality, or an MCA, or a CPR abnormality. This is exactly what the guidelines tell you as well. If you understand why, it becomes a lot easier to interpret these guidelines. So the guidelines for early onset FGR says that if you have any of these 3 critical abnormalities, which tells you that the baby is in what stage? Acidotic stage. You would deliver as soon as the baby is salvageable. There's no point in waiting after that, because that can induce a lot of damage to the fetus. But if you have not reached those direct triggers for delivery, but you have reached a stage where there's an absent and diastolic flow, that tells you that the baby is still severely hypoxic, not acidotic. You'd probably deliver any time after 32 weeks, but you're permitted to wait with until 34 weeks if you can put them through a very intense surveillance protocols of daily CTGs or daily BPP assessments. If it's reversed, we said it's again between severe acidosis and between severe hypoxia and acidosis. And as soon as you're assured of lung maturity, you would definitely deliver, but you're permitted to deliver even after 30 weeks. So that's for early onset FGR. Whereas for late onset FGR, it's again the same thing. If you have those very late changes, remember we don't look at the ductus venosus in late onset FGR, because the ductus venosus is not going to be abnormal because your heart is relatively spared. But if you have the other 2 abnormalities of BPP and unprovoked late decelerations and CTG, then that is an immediate delivery trigger. You would deliver immediately. But if you have the other Doppler abnormalities, which tells you that the fetus is hypoxic and trying to compensate, you would deliver as soon as the baby reaches term, or maybe after 36 to 38 weeks. Now, you see a baby that's growth restricted, you look at all of these triggers. Your first thing that you want to do is to try and see if there is a trigger point for delivery. When you find all of these Dopplers are okay, when there are changes but none of your delivery triggers are hit, and that is when you institute what you call as fetal surveillance or antepartum fetal surveillance. Now, how or when should you, what would be your frequency of surveillance? Well, none of the guidelines give you a consensus, either for early onset or late onset FGR. All that the guidelines tell you is to follow local protocols. And what local protocol can you follow? The best thing that you can use is the Barcelona protocol, which tells you very objectively as to how do you survey these babies if you don't hit your delivery triggers. Now, it's impossible for me to explain this in 2 minutes. What I would suggest is all of you have a printout of this in your clinic. Keep looking at it a second time, a third time, a fourth time. By the time you get to 10 times, you'd probably have this at the back of your head and you would not have to go back and look at these charts, because your Barcelona charts are very, very clear. They tell you exact. Yeah, sure, ma'am. I can share this. This is widely available on the internet, but I can share, no problem. So you can stick this to your clinic and it becomes very, very objective. So this is exactly similar to what these SWOG guidelines tell you, except for a couple of changes, but that does not have significance in terms of real life management. So you can use this protocol very well. Not much to choose between SWOG and Barcelona, but I feel this is a lot less confusing and a lot more objective. And if this is still confusing for you, they also give you a chart which tells you exactly what to do for each of these stages of growth restriction. If it's severe placental insufficiency, what you do. These are your criteria for diagnosis. This is how you monitor, and it also tells you how and when to deliver. So this one chart stuck in your clinic can make your management of fetal growth restriction much less complicated and very, very easy and pragmatic in time to come. The last question often asked is, how about steroids and Maxilf in FGR? Well, steroids is a strict no, because these babies that are growth restricted already have a high level of endogenous steroids because of the stress of hypoxia. Therefore, you don't want to pump in more steroids to this baby. That can do more harm to the brain than good. Maxilf, certainly yes, because Maxilf has been shown to be neuroprotective. Again, it is neuroprotective if you have to deliver these babies up to around 30 or 32 weeks of gestation. Again, between 30 and 32 weeks, you could still follow local protocols. So those were the 10 questions. If we quickly go through the 10 to summarize this lecture, remember, definition of FGR has never changed. It's a failure of the baby to live up to its endorsed growth potential. What has changed is the criteria for diagnosis. You cannot measure growth potential, therefore you have to use size as a proxy. We said the fallacies of using size as a proxy, but that is the best that we have to work with. Smallness is defined as any fetus that is less than the 10th centile in either estimated fetal weight or abdominal circumference. Which growth chart is the best? Whatever you feel is best is the best. There's no consensus that tells you that this chart is superior to the other. Any which chart you say, there are disadvantages and advantages. So whichever works best for you in your population is the best growth chart as far as you're concerned. How do you exactly diagnose FGR? We said there are definite criteria in place. We spoke of the 3 criteria: either a baby that's extremely small, or a baby that is small with demonstrable placental insufficiency or fetal adaptation, or a baby that is not small yet but definitely getting there with demonstrable fetal Doppler abnormalities. Early versus late, we said you could use 32 weeks as an arbitrary cutoff, but it's basically a continuum. It's just 2 different phenotypes of the same disease process. One that happens when you have a very severe placental insufficiency, the baby growth restricts very early in gestation, and you have abnormal umbilical artery Dopplers. The other phenotype where the placental disease is not so bad, so your umbilical Dopplers may not be really bad, but the baby is not maintaining growth, and growth restriction happens very late in gestation. How do you manage FGR? I said the best thing to do is to get a printout of the Barcelona protocol, stick it to your clinic, and keep following that. That's the best way that I can summarize, because it's not possible for me to go through the whole management again. But if you understand the concepts that delivery timing, optimal timing of delivery is the most key management concept in FGR, and for that you need to balance hypoxia, severe hypoxia, acidosis, and lung maturity. And once you balance all of these, you decide which is best for this particular baby. Every case has to be individualized, but has to be protocol based, so that two different consultants in two different parts of the world would do exactly the same thing for a fetus that presents with the same Doppler abnormalities. So that's what the Barcelona protocol has done. It is objectified decision making in FGR, which is why I implore all of you to follow it. The ISWA guidelines are good. There's a consensus definition, but it's slightly more confusing if you go through it, whereas I find Barcelona a lot easier to follow. So what if there are no delivery triggers? We said the direct decision is to deliver if you have the triggers, but if you don't have delivery triggers, is when you would continue fetal surveillance by Dopplers in early onset FGR, more predominantly with BPP, and of course Dopplers as well in late onset FGR. The frequency of surveillance, again, there's no consensus. Here again, you could fall back on the protocols, the Barcelona protocol. Steroids, yes. Steroids, no, because the babies have high endogenous steroids. Maxilv, yes, because it has been proven to be neuroprotective. Thank you. Yeah. Sorry, that's a mistake. I mean, for early onset FGR, definitely yes, but not for the late onset FGR. But you have data that comes in that even for early onset FGR, the intrinsic steroid that the baby has is much higher than if you don't have FGR. So that is supposed to cover for your pulmonary insufficiency, and you really don't need to pump in more exogenous steroids, even if it's less than 32 weeks, yes. But we still haven't gotten to that point. Our neonatologists would not agree to that at this point in time. So for early onset FGR, we still give steroids and deliver, but late onset, we don't, yeah. For? Which one, ma'am? For steroids? Steroids, we do the same thing. Till 32 weeks, we give steroids, because otherwise your neonatologists are not happy enough, they're not convinced enough. Beyond 32 weeks, we have managed to convince them that you don't really need steroids. True, yeah.
You have to give steroids. That's
Correct.
it.
So any debatable concept, if you see, you'll find guidelines that are for and that guidelines that are against. But like we said with NIPT in the morning, it's for us to read between the lines, to read the fine print, and then decide what best suits your baby from your own practical experience as well. So what we have found out is 32 weekers, when early premature babies that are born below 32 weeks and not given steroids, because sudden preterm delivery, for instance, they do not really have the same kind of lung issues that you have when you deliver a 34-weeker for PPROM, for instance. So if your steroids are really not required in growth-restricted babies, why do you really want to pump in endogenous steroids? Because that has been shown to cause leukomalacia in fetuses. Periventricular leukomalacia is a direct effect of exogenous steroids. Yeah, so this is still a controversial area, I agree. We still do not have hard and fast rules. The fetal medicine papers, if you look at the fetal medicine literature, that says don't give, but if you look at obstetric literature, it says give. So that is still a debatable point.
And sir, one more question. Whenever we are doing growth scans at 32 weeks, and so do we have to combine it with Doppler all the time, or uterine artery Doppler all the time, all scans?
If the baby is growing absolutely fine in terms of growth centiles, and if you look at the growth chart and the baby has been maintaining growth, we do not look at Dopplers. Because quite often, you find in an absolutely normal baby, the Dopplers could be abnormal. That could be because of cord compression, could be because there's a cord around the neck, it could be because of an eccentric cord insertion, but that really has no relevance or no bearing on the fetal outcomes unless the fetus is small or not maintaining growth. So if the fetus is growing normally and it has been maintaining growth, you really don't need Dopplers.
Sometimes, due to unavailability of the sonologist, in late onset FGRs, can we take the decision of the delivery just on the basis of CTG, NST, considering BPP?
Yes, provided your delivery target of an unprovoked late deceleration is hit. If you have an unprovoked late deceleration on your CTG, that is a direct delivery target. You don't need Dopplers. You don't need all the three criteria to be satisfied. If any one of those three red criteria that I showed you are hit, that is a direct trigger for delivery.
We are not doing ECTG, we have normal.
Not required, madam. Unprovoked late decelerations are not a CCTG TA finding. It's basically on the routine CTG.
So that is justifiable?
Yeah. So if you have a computerized CTG, you would look at short-term variability, not at decelerations. In a conventional CTG, you can look for unprovoked late decelerations. In a computerized CTG, you would look for a short-term variability less than 3 milliseconds. So which is why I didn't mention that, because none of us in India use computerized CTGs. We always rely on the old CTGs. And in the old CTGs, the conventional CTGs, it's unprovoked late decelerations that are a trigger for delivery.
Yes, in late onset.
Even in the early onset FGR, if you hit one of these targets of DV abnormality as an absent or reversed end diastolic flow in the reversed A wave in the DV, unprovoked late decelerations on the CTG, or a short-term variability less than 3 milliseconds, or a biophysical profile less than 4. After 26 weeks, which is your salvageability, you can still deliver. Yeah, so that's where we fall back on the dating scan. You would look at the CRL measurement.
No, we have
If the CRL measurement has been taken appropriately as per the guidelines,
yes,
then you're sure of the dates. So the first thing is to confirm the dating. If you're sure of the dates and the baby is showing, again, the weeks lag does not apply in practice for us. We always look at the centiles. Even a baby that is showing...
It's less than 3.5 percentile. The baby's growth is less than 3.5 percentile. I have such patient at present. Dr. Devashish is doing the Doppler as well as growth scan.
So at 35 weeks, the baby is less than the third centile.
Yes.
Yes. So that is FGR by definition. As you said, any baby that's less than third centile is FGR. You look for intrinsic causes first. If there are no intrinsic causes, you look at Dopplers. At 35 weeks, if you have a baby that's less than the third centile and a Doppler abnormality, that is definitely severe growth restriction, and you could deliver at 35 weeks after steroids if indicated, but usually we don't give steroids after 32 weeks of gestation.
That baby should be delivered.
Again, depends on the Doppler abnormalities. I mean, assuming that there are bad Dopplers.
Yes, the umbilical artery Doppler is all right, but the
Actually,
other
madam,
Doppler
there are multiple things. He has showed one table that less than third centile is defined that it is FGR. Now, when to deliver and how much you can wait for lung maturity, it depends upon the other features of the Doppler which has been shown in early FGR and late FGR.
Yeah.
So, there is a table by consensus opinion from ISOG that if you follow before 32 weeks, one thing is very clear that if it is less than third centile, then this baby is definitely and growth retarded. But less than 10th centile, other features are included. But less than third centile, if you want to deliver and you want to wait, because you have to balance it between the lung maturity and the fetal death. So thing is, there are two tables which is depicted by ISOG and consensus. This is a very common controversial thing. So people have decided, they came together and make a table.
Barcelona.
What he has shown in between, because
Barcelona
it is very
protocol.
complex table. That's why I think he avoided that, because uterine artery, ductus arteriosus, umbilical artery, how much centile in the Doppler you have to decide. So it is a comprehensive opinion by the sonologist. That message goes to you that this is the status and this is the baby is at hypoxia or acidemia. Now you deliver.